Stay with us for the next 30 minutes as you meet our doctors like never before. A program that will allow you, our viewers, to make more informed decisions when it comes to your health care.
This is one of our community seminars that we like to do just to provide education for those in the community that have inquiring minds and would just like that one-on-one interaction with a physician. This gets you out of your normal setting within the room back in the doctor's office and just opens up conversation to have with Dr. Richter today. So we thank Dr. Richter for doing this. We had a very successful talk on arthritis a few weeks ago and actually maxed out the classroom. We had almost 60 people. So it brought to light how arthritis is a hot topic in our community. So we'll probably do several more of these. So let your friends and family know that as well. So,
but I get really unoriginal after the first one. So just.
So without further ado, Dr. Richter.
All right. This is going to be kind of this is sort of an introduction, so we'll cover a lot of stuff. I'm going to go over some sort of basic hip and knee arthritis things because those are certainly the things that we see the most, and we're going to do, in this talk today, hip arthritis, knee arthritis, and shoulder arthritis, and kind of some treatment options in general for arthritis and specifically for hip, knees, and shoulders. Arthritis covers a lot of different things. We don't have the projector, so we printed up for you guys the slides that are here, and I'll kind of go through those a little bit. But, you know, the first thing is a lot of people are, and I want you guys to ask questions, by the way. This is for y'all. We do these seminars for education for you guys, and so the whole point of this is for you to get your questions answered. So I want you to feel free to ask questions if you have questions. Tracy gets mad at me, but probably the best way to do that is if you have your question, just to ask it. Because I know for me, when I'm in a talk, I'll think of a question, then I forget it by the time the thing's over with. So if you think of something, just let me know if you have a question. One of the common things that I get questioned about by people when they come into the office is just that they don't really understand exactly what arthritis is. So, you know, because people will ask me, can you just cut the arthritis out, or can you do this? And that doesn't really make a lot of sense when you understand what the disease process really is, but it's because people don't really understand what arthritis is. So what arthritis is actually is loss of cartilage in a joint. And so when you're born, you have what's called articular cartilage. Articular means joint, so it's cartilage for your joint that goes over your joints wherever there's bones that rub together or roll across each other. And that's a very good substance. It's something that we've not been able to reproduce. So it's one of those fearfully and wonderfully made by God things that we just can't make anywhere near as well. So articular cartilage, when you're born, covers your joints. When you roll and move your joints across each other, it makes them move smoothly and not catch or hurt. And that, for most people, that will last you for an extended period of time. Hopefully, until you're up into your 60s, 70s, 80s, or even beyond for a lot of folks. In all honesty, so as that cartilage starts wearing out or degrading over time, that is what arthritis is. So arthritis is not something that is in you that's not supposed to be there. It's something that's not in you that is supposed to be there. So we can't remove arthritis because that's what it is. It's something that's gone that's supposed to be there. So there's a lot of different types of arthritis, and if you'll flip through your slide, osteoarthritis is good old wear and tear arthritis. There's no particular cause for it other than just we see it more commonly in a 70-year-old than we do in a 7-year-old because you got 70 years of wear and tear on your joints versus 7. So the more you wear and tear on your joints, the more you have loss of cartilage. Rheumatoid arthritis, gouty arthritis, psoriatic arthritis, there's various different forms of these. Rheumatoid arthritis is a type of arthritis that's caused by a sort of a reaction in your body almost to the lining of your joints in your body. And so you'll get, over time, that just wears it out and it eats it up. So that's rheumatoid arthritis. You can see arthritis associated with lupus, which as well is an autoimmune type disorder. All these things have specific causes that we can treat. You have gouty arthritis, which is associated with a disease that we call gout, or pseudo-gout, which is just a different thing that gets deposited. And what happens there for gout is that you have what's called uric acid that builds up in your body, and your body can't get rid of it, and it gets deposited into your joints as crystals that are shaped like little needles when you look at them under a microscope, and that's generally the way that people describe it as well. So it's not very, very fun to have. You get a gout flare-up, it feels like there's needles poking you in your knee or your toe or your wrist or elbow and various different things like that. Psoriatic arthritis is associated with psoriasis. You see people that get the patchy little scaly things on their elbows or ankles and knees and things. That's called psoriasis, and that is associated with arthritis as well. So for various different things like that, we will see that these particular diseases have arthritis associated with them more frequently. But the one that you guys normally are talking about when you come to see me, unless you happen to have rheumatoid, for most people by and large, is osteoarthritis, or also called degenerative joint disease. Okay, and that's a very good description. Your joints wear out over time, and you lose that cartilage. So the question is, what do we do about it? Well, generally speaking, when you have arthritis, there's a couple of things that we want to do to treat it. Number one, you want to keep your joints moving because stiffness is a very, very common complaint associated with arthritis. So one of the more common things that we get when people come in to see me, they'll come in to see me say they're having knee pain, they have knee arthritis. We question them on what's going on, and what their symptoms are. They'll say, when I get up in the morning, my knees are stiff and I can barely move. And as I get up and get moving around a little bit, it'll feel a little bit better, but then when I'm up on them for a long time, they hurt. But morning stiffness or start-up stiffness is a common arthritic complaint. So one of the first things that we do when we're treating arthritis is try to keep your joints moving. And we do that by sending you to therapy. There's a lot of different modalities and things that we'll do. But we basically a lot of times we'll send you to therapy or have you work on exercises at home. So the goal is we want you moving the joint, but we don't want you beating up the joint. So bicycles, swimming, elliptical machines are all really good exercises for arthritis because they move your joints without beating them up too much. Going out and running is not so great because that obviously pounds on your joints. So we want to limit that a whole lot. Aquatic therapy has become something that we do a whole lot, that's become a lot more common for arthritis now. They do that at the fitness center, and Stacy's over there that does therapy for us. But aquatic therapy has become common, one of the common things that we do for arthritis now. Assuming you're not afraid of the water, that's a very good exercise for arthritis because being in the water takes the weight off your joints. So it offloads your joints and allows you to do some aerobic exercises and things like that will keep your joints moving but without causing so much pain. The next step in treatment really is medications, and there's several different. Yes, ma'am.
Is it appropriate for us to use the one like at Clark where we sit and use the rubber bands and the balls and all that?
Yeah, I mean generalized strengthening, but what we're looking for from the standpoint of like if you're seeing me for knee arthritis, what I want you doing is keeping the joint moving. So, what you're talking about with using bands and stuff like that, you're using just generalized resistance.
Yeah, we do the what you call football shuffle, and we move the joints. We just sit up and down.
Yep, that's what we want. We want it moving. That's a good thing. Anything with arthritis, we want to keep it moving because you don't want to get stiffness. Yeah, I'm not going to argue and tell you to get off a treadmill if you're tolerating it okay. I mean, the bottom line is that you're probably, from the standpoint of if you have substantial arthritis in your knees, you're probably better off on an elliptical machine or on a stationary cycle that's not causing as much impact. Having said that, the health benefits of you aerobically getting your heart up and running from a walking standpoint, are good. And so I'm by no means going to tell you I don't want you to get out and go walk. Right. Yeah, when I say non-impact stuff, I'm talking about lower extremity arthritis. So hip and knee, feet and ankles, those types of things. So if you have arthritis in your shoulders or something like that, then yeah, treadmill's perfectly fine for that. So we're generally speaking the range of motion without beating up. When I say that, I'm talking about lower extremity arthritis. Okay, so after range of motion, the next step in treatment really is medications, and there's a lot of different options there. Now, generally speaking, the mainstay of treatment for arthritis is anti-inflammatory medications. It's a class of drugs called non-steroidal anti-inflammatory drugs, or NSAIDs, of which Advil and Aleve or ibuprofen that you buy over the counter are in that class of drugs. There are a couple of problems with those medications. Number one, if you take them for long periods of time, or sometimes even short periods of time in people, they can cause stomach problems, including ulcers in your stomach. That's a long known complication of taking those medications. The bottom line is you take a population that's in their 60s or 70s or 80s, a lot of you guys don't have the best stomachs in the world, and so anti-inflammatory medications aren't really a good option sometimes. The second problem with those medications, and again, this is true of Advil if you go buy it over the counter, this is true of that medication just as well as it is of medications that we prescribe. if you take anti-inflammatory medications, particularly in high doses for long periods of time, they absolutely elevate your risk of dying of a heart attack. Now, again, that's why I preface that by saying this is true of Advil if you go buy it over the counter. The bottom line is this. The studies have never told us that if you just take those medications intermittently that they elevate your heart risk, but they do if you're taking them in high doses for long periods of time. If you're taking 800 milligrams of ibuprofen 4 times a day for extended periods of time, it elevates your heart risk. We know that that is true. And so a lot of you guys, primary care doctors now will tell you don't take anti-inflammatory drugs, don't take NSAIDs. Because of if you have hypertension or high blood pressure or you have hypercholesterolemia or high cholesterol, you're already at elevated risk of heart problems, and so a lot of times they'll just tell you can't take the anti-inflammatory medications. So the prescription strength versions of those drugs that we use, like Celebrex or Mobic or Voltaren, those are probably the 3 that I use the most common. A lot of times those are off the table for you guys as a form of treatment for your arthritis because of the risks associated with them. In a 20-year-old, it's not as big a risk, but those people don't have arthritis as often as an age group that has higher heart risk anyway. For me, when I'm prescribing those medications, if you have a super elevated heart risk, I'm not going to put you on one of those medications. I will tell you up front that that risk is there and that I only want you taking it as needed. Again, those studies have never told us that if you're just taking Advil twice a week because when your joints ache just twice a week, that elevates your heart risk. But with that out there, it's questionable. So that leaves the other over-the-counter option, which is Tylenol. Tylenol is not an anti-inflammatory medication. It probably doesn't do as good a job of controlling your pain as the other anti-inflammatories do, since it's not an anti-inflammatory. But it is there as an option. There is Tylenol Arthritis, which is not really an arthritis medication, but it's extended-release Tylenol is all it is. So that's an option for you. That's over-the-counter medications. The next step would then be prescription medications, of which, the anti-inflammatories we just talked about. The other option is a medication called Ultram, which is kind of a pain medication, but not a high-end pain medication or narcotic like Lortab or Vicodin or something like that. I use Ultram sort of intermittently. I find it to be a reasonably good option if you're just really looking for pain control. Generally speaking, I'd prefer to really get the disease under control as opposed to just putting you on a medication, though, in all honesty. So if I feel like if I have to just have you take something 3 or 4 times a day to try to get it under control, then we're not appropriately treating your problem and we need to do something different. And then there's narcotic medications like Lortab or Norco or Vicodin. These are usually some combination of oxycodone or hydrocodone. They are narcotics. They are controlled medications. For me, I don't like to treat arthritis with those medications. I mean, again, unless you have a contraindication to us going to the next step, I don't want you to just be on pain meds. I don't think that's necessarily a great treatment. If it comes to that, then we have pain management doctors that we generally will get you to work on that. Okay, so medications. Yes, ma'am.
Is it true Tylenol is really bad for your liver?
Tylenol.
I read that.
Yes, and say Tylenol and the anti-inflammatories are metabolized differently, and that's why they're different. So the anti-inflammatories or non-steroidal drugs like Advil or Lever are not so great for your kidneys. Tylenol's not so great for your liver. Usually only in high doses, though. So if you take Tylenol at recommended dosages, it should be fine as long as you don't have liver disease already. If you take Tylenol in higher doses than what's recommended, you can damage your liver, and that is not a recoverable thing. So if you OD Tylenol and mess up your liver, that's forever. So next step, medications. So range of motion, medications. Next step is injections. There's 2 different types of injections that we largely use to treat this. One is steroid injections or cortisone shots. Cortisone is a type of steroid. We'll go into that in a little bit. The second is what's called viscose supplement injections. So the first step that I would generally do is a steroid injection. Steroids are a single shot, usually fairly rapid relief, cheaper than the other ones, so we start with that. So what a steroid is, we just talked a little bit earlier and we said those medications are called non-steroid anti-inflammatory drugs. So this is steroid. The steroid's a very, very potent anti-inflammatory medication. It helps, just think de-irritant. It's a de-irritant for your joint. So we inject it where the problem is. We put it in the joint, knee, hip, shoulder, and it helps just generally de-irritate the joint. This is treating the symptom, not treating the problem. When you have arthritis, it goes back to what we talked about at the very beginning. I can't cut it out. Okay, we can cut it out and do a joint replacement, but we'll get into that a little bit. But it's not a simple solution. So when we're treating you, we really are just saying we're treating the symptoms. You're still going to have the arthritis. We just got to make it not hurt. Okay, so that you can get on and do what you need to do. Okay, so the steroids is a de-irritant, helps generally de-irritate the joint, and can make your symptoms go away. Issues with steroids. They work really good typically, but they're very variable on how long that lasts, even in the same person. So if she comes in and sees me and says, my knee's hurting and I need a steroid injection, and I inject her knee and it lasts for 6 months the first time, the next time she comes in to see me, it may last for 6 weeks, or it may last for 6 days, or it may last for 6 hours. Right, may not do anything. Right, yeah. So steroids are very, very variable, and particularly in the same person, and particularly after they've been used for longer periods of time. So generally speaking, if you are steroid naive, in other words, you come to see me and this is the first time you've seen somebody about your knee and you have arthritis and you've never had an injection, it usually will work fantastically well in those people, but not always. But steroids generally can give you some relief. You do not want to have those injections done more often than 2 or 3 times a year, because over time, if you repetitively inject these, they can cause damage to cartilage. Now, you've already got bad cartilage in the knee. That's why we're doing the injections to start with. So that's not, absolutely can't do it. And again, a lot of this varies based on the person. If you come and see me and you just can't have surgery because you have terrible lungs or some other major indication to having something done, I'm going to be way more aggressive about injecting steroids.
If you have bad bones, does that affect if you went for a knee replacement?
Well, in theory, the steroids can cause some softening of the bone, but we don't. I got to say, I don't know that I've ever really seen that be an issue from the standpoint of having the surgery done in people that have had steroids. There are certain disease processes, like really bad asthma or people that have really bad backs, where they take steroids by mouth a lot, and you can take a steroid by mouth as well for this. It's called Medrol or prednisone. If you're on long-term steroids, it can cause softening or weakening of your bone in general.
I mean, if you have osteoporosis.
Right, that's what I'm saying. So if you're taking long-term steroids by mouth, then it can cause some generalized softening or weakening of your bone, but you still should be able to, that should not affect the ability to have a joint replacement done. So the bigger thing with the steroids is just that, you're not going to be happy if you got to come into my office every 2 months and get a shot. But they generally do a pretty good job, and they generally work fairly well. They're very variable. And again, so we generally will say limit those to, not more often than, 2 or 3 times a year on the steroid injections. So if I give you a steroid shot and it just doesn't last very long, then the next step is to go to what's called those viscosupplement shots. Those go by a lot of different names: Synvisc, Suparts, Hyalgan, Euflexa, Orthovisc. There's several different ones. People call them chicken shots or the rooster shot. They're made seriously from rooster combs. So the little thing on the top of the rooster's head, that's what most of the medications are made from. And so people call them chicken shots. I have seen those medications be a miracle for people. I mean, I really have. I have seen them be the miracle shot for people. I've seen them not work on people. So most people fall somewhere in between. The studies on them are very good. The medication is called hyaluronic acid. That is a normal component of the fluid in your knee joint, but we don't really know how it works. It's thought that it somehow just thickens up or modulates the properties of that fluid so that it lubricates your knee better and takes away pain. The studies tell us that if you have mild to moderate arthritis, you can expect an 80 to 90% reduction in your pain. If you have severe arthritis, 50 to 60% reduction in your pain. That number sounds pretty low, probably, but that's the difference in being stuck in your house and being able to get out and go grocery shopping. So I've seen them work really, really good. My experience with those medications really came when I was in training at a VA down in New Orleans. We had a lot of folks that just needed surgery done and couldn't get it done, and we used those medications a lot to try to get those people through, and they did a lot of folks did really, really well. They work well enough that I really won't do a knee replacement on you if you haven't had those shots, because that may keep you from having to have it done. So it's definitely worth trying. So That medication, visco supplement shots, are only indicated for knee arthritis. You can't get that shot anywhere else. It's in the knee, and it's typically a series of shots, 3 to 5 shots. It depends on who makes the medication. There is a single shot formulation called Synvisc 1 that's out there. I generally use a medication. I use Suparts. I did not like. I've used the one shot formulation in the past. I didn't particularly think that I got as good of results with that. That is not scientific. Okay, I did not do a study on that. My patients didn't seem to like it as well. That's anecdotal, I know. They seem to do better with the Suparts, and I've been pretty pleased with that, and so that's the one that I use. But that you can only use that in a knee. So if your problem is hip arthritis or shoulder arthritis, you can't get that shot in the knee, no matter how hard you beg me. And I've had people come in and say, I want the chicken shot in my shoulder.
What about the fingers and thumbs?
No, only knees. So if you're dealing with arthritis in smaller joints like thumbs, and this is a common place, what's called basilar thumb arthritis, where you get sort of almost like a crunching or a grinding at the base of your thumb. These are a little bit more difficult to treat because it's just a smaller joint. So you can get a needle in there and do steroid injections in those joints, and they usually will work pretty good, in all honesty. So I have sort of a cohort of folks that have basilar thumb arthritis that will come in about once a year typically just to get an injection. So usually that does good. Basilar thumb arthritis is interesting because, again, we're talking about arthritis at the base of your thumb. That's an interesting disease. Right, yep. You can get it here or here. It's an interesting disease, though, because we'll see it show up on X-ray a lot in people that are completely asymptomatic. So, like, we'll have people that will come in for something wrong with their arm, and we'll take an X-ray and see at the periphery of the X-ray we'll see bad basilar thumb arthritis. They'll come in for a trigger finger or carpal tunnel syndrome, and we'll take an X-ray, and they got terrible looking basilar thumb arthritis. And so we say, "Is your thumb hurting?" They say, "Nah, it doesn't bother me at all." So that's an interesting little disease because a lot of times it's asymptomatic. But in some people, it hurts. And so usually we can inject those folks and kind of get them along fairly well. The biggest issue with that one usually is grip. Can't grip very well.
Can't get that finger the way it should be.
Can I ask you a question? Okay, my problem is when I get one, I can't. This like now. That's how I can.
They won't bend. Yeah. That goes back to the very first thing we said, which is stiffness associated with it. So as you get arthritis, you typically...
It's still like that.
Yep. As you get arthritis, you typically will lose range of motion in your joints. So, I can bend my knee back to my rear end. If you've got knee arthritis, you usually can't bend your knee back more than about 110 degrees or 90 degrees a lot of times. So you lose motion generally as you go along. Do what? You can get it there, but just not back. So loss of motion is kind of a common thing anyway, and that's why we say one of the initial treatments is really try to keep as much motion in the joint as you can. Stiffness makes joints hurt, so when you're, one of the things that drives the pain with this is just stiffness in general. So if you have lack of motion, whenever you try to go beyond where your motion will allow you to go, it's going to hurt. So in other words, for you, if your fingers only go here, every time you try to bend them beyond that, it's going to hurt. Likewise for your knee, if it'll only bend 90 degrees, every time you try to bend beyond 90 degrees, it's going to hurt. Well, for most folks, most people when they sit with their knees. Every single one of these folks have got their knees bent more than 90 degrees. Same thing back here. All you guys have got your knees bent 110, 100 degrees or so. So if you get bad arthritis and you get stiffness, every time you go to sit down, it's going to hurt. The only thing you can do, hands are a little more difficult to treat. Smaller joints in general are a little more difficult to treat because you really are sort of. There's not a great surgical solution for those. There are joint replacements to small joints in your hand, but for what you're showing me where you really are having trouble bending your fingers down, you've likely got sort of just generalized osteoarthritis in your hands, which is multi-joints, and we can't go in and replace, all those joints, so you'd be terrible if we tried to do that. So generally speaking, for really small joints like your hands, surgery still is centered around fusion procedures to treat that. And so what that means is if your fingers hurt so bad when you move them, then we just make them not move and then they don't hurt because they're not moving. But obviously you sacrifice your motion then to gain pain control. I tell folks for stuff like that, you really got to be bad off to choose that option. You really have to be struggling so bad to just say, I'm willing to not have this not move to make it not hurt. That's a tough call.
Sometimes if you just open them and close them,
Right, and that's your range of motion. That's exactly right. So stiffness, and this goes stiffness and fingers. But as this progresses, you can't get it all the way closed, or you can't get it all the way open. So, and again, likewise for people that have arthritis, when we talk about not being able to bend your knee beyond 90 or 100 degrees, it's not that they're not trying; they just can't do it. It just over time you get extra bone that forms and things like that prevent it. I'm sorry.
Lower back pain, do you give shots for that?
I do not do the shots for lower back pain. We do our anesthesiologists at the hospital do those. Epidural steroid injections. So, yes, ma'am.
How often can you get those steroid shots if you need them?
Again, not more often than about 2 or 3 times a year is what we recommend. It depends on, what disease we're treating, what joint we're treating, what your concurrent medical conditions are. So, again, if you're pretty healthy, I'm not going to give you shots every 2 months to do it. If you have terrible lungs or bad COPD or your own oxygen all the time and you can't go to the operating room and have a knee replacement, then I'm going to be a little more aggressive about giving you injections for that.
Is bursitis a type of arthritis?
No, bursitis is different. It's an inflammation or irritation of a structure called the bursa, which is a collection or a sac of fluid that overlies prominent bone and bony areas.
What does steroid shot with that?
Steroids do help that. Yep. Again, steroids are general anti-inflammatory de-irritants, so they help a lot of different things.
I had 2 shots and it didn't help me.
For hip bursitis, shoulder. Well, and there's a lot of things that could be. That's a whole nother talk. I could do a whole talk on just shoulders too. But all right, so beyond injections and things like that, then surgical options for arthritis really are centered around, for big joints, are centered around joint replacement. Now, for your knee, you can see arthritis that is localized to just the inside part of the knee, and you can do a partial knee replacement or you can do a total knee replacement. When we do that, we go in and remove what little bit of cartilage is left, and we replace that with metal with a piece of plastic that goes in between them. So you no longer have bone rubbing on bone, you now have metal rubbing on plastic. That should not be painful. Now, this is a big surgery. It takes a little bit to recover from, and it depends on which joint you're having replaced. So if we're talking about knee replacement in particular, it's a good surgery. It works very well. It has a very high success rate. It takes work on your part.
I have a question. Okay, what happens if you got a knee and when you move it, it clicks? It feels like it's rubbing on.
Well, I mean, that can be caused by arthritis as well, because it could be that you're getting clicking or rubbing because of the knee being just worn out and not having cartilage and stuff. So a lot of that just depends on what's going on. There are other things that can be wrong in your knee that can cause clicks and pops, like meniscal tears or things like that as well. But generally, again, from an arthritis standpoint, we would have to evaluate that and see. If you have substantial arthritis, then really the only surgical option for you is a knee replacement. You can have arthritis and a meniscal injury as well, with the meniscus being like a little C-shaped piece of cartilage that sits in between the two bones of your knee and acts like a shock absorber. The studies, though, have told us that a knee scope will not help your arthritis at all. So if you have bad arthritis and you see me, I'm going to tell you that a knee scope's not worth your time. I'm not going to put you to sleep, put you through the risks of surgery, go in and clean up a meniscal tear, and you're still going to have arthritis. And we know good and well that surgery is not going to help at all. I just don't find that to be very useful for you. Yes, ma'am.
What implant do you use for the knee?
I use a company called Biomet. Biomet, B-I-O-M-E-T. My partner uses, I believe, Zimmer or DePuy, I think is who he's using. It varies around. The bottom line is this, and I don't know where that question is that question asked for a specific reason in regards to like a recall or something like that? Every company out there has recalls. I mean, it happens, unfortunately, off and on. It's no different than Chevrolet, Ford, GMC, Honda, whatever you happen to choose. The bottom line is that there are things that happen with those implants sometimes that lead to recalls, and every company has recalls. Biomet has a really good track record, I will say with that. It's been a good company for me, but in all honesty, if you look at the statistics, Biomet, DePuy, Smith & Nephew, Zimmer, their replacements all have about the exact same survivorship. So really it comes down to what I'm used to, what I'm happy with, and who has good reps, and who's going to take care of me from the standpoint of the company, making sure I have the implants that I need and that kind of stuff. So when we do these replacements, in the operating room, all of your implants that we use are sterilely packed, and they're controlled by the company, not the hospital. So there is a representative for the company that has to bring all that stuff to the hospital. And when I say, I size it, we have trials and stuff, and we'll put it in, and I say, okay, I need this. He opens a brand new, out of the box, special, clean, sterile implant onto the field for me to use. So in all honesty, a lot of my choice of company that I use is just because Biomet's been a company that has historically worked well for me. Their reps have been good to me from the standpoint of, when I call them, they're there, they respond appropriately. I don't get paid by anybody. There are some doctors that get money or get paid as consultants for various different companies. I don't get paid by anybody. I mean, I'm a private practice guy, so I don't do a lot of research, and that's usually the guys who get paid. So it's just a lot of it just comes down to the reps, and we got good reps. I've had good reps with Biomet, and I've been very pleased with them, and they work well with the hospital, and so that's what I use. But there's a lot of people get upset or worried about the recalls, and certainly the company's not going to sell you something they know is defective, but the biggest recall that's happened recently has been in metal-on-metal hips. So when we talk about doing joint replacements, again, metal, and a piece of plastic in between. So for your knee, metal up here, metal down here, and a piece of plastic in between. For your hip, metal down low, metal ball, metal socket, and a piece of plastic in the metal socket. So the metal ball generally rubs on a piece of plastic. The weak link in that is the piece of plastic. So it doesn't last forever. I mean, the metal should last. Most of these things are cobalt chrome, which is an alloy of those two of the multiple metals, but that's strong. The problem is the piece of plastic doesn't last forever, and so that wears out over time. So there's been experimentation with ways to get different what are called bearings, particularly we're talking about in hip replacements. So one of the things that people said is metal on metal. Why don't we do metal on metal? Because it still won't hurt. Metal on metal is still very smooth. If we do the right metal, then we shouldn't have to worry about the plastic wearing out. There's a couple of things that came out of that were problematic. Number one, it absolutely puts cobalt chrome ions into your bloodstream. Now, all the research that we have done on that to this point says that probably is no big deal. We don't know for sure, though. I mean, but there's not been anything to indicate that slightly elevated levels of cobalt chrome in your bloodstream causes a major problem. But the second thing that started showing up was around these metal-on-metal hips. They started noticing that people would come in and they'd say, I'm having pain in my hip or something, and they do a test and end up doing an MRI to check and see, and they started seeing these big things that look like cancers, but they weren't cancers, and they've officially called them pseudotumors, but they were big enough and problematic enough, and people didn't know exactly what they were, that that's where a lot of the recalls came from. So metal-on-metal hips are still done some, but they really have largely been abandoned. And that the most recent large recall happened in metal-on-metal implants. The other alternative bearing option is ceramic. Ceramic on ceramic hips. That should be really smooth too. These have a very interesting history. A lot of, I know you guys don't like to hear it, but a lot of this stuff is trial and error over time. It looks good, it should work out well, and sometimes it doesn't. So that's what happened with ceramic on ceramic to start with. The original ceramics on ceramic showed almost no wear whatsoever. Fabulous, right? So what happened was sometimes they'd just blow up. They'd crack. And then when they did, the whole thing would just like pulverize. And I've been in a couple of those hips when I was in residency, and it is a disaster because you're going in there picking out little pieces of ceramic trying to clean it out because it's like the whole head just blows up. That was the old ceramic. So what happened was that the ceramic was brittle, and so over time something would happen, or it would hit just right and it would not good. So that's hard to get rid of. So that problem has been fixed. So the new ceramic that we use is no longer brittle. The issue with the new ceramic on ceramic hips is that they'll squeak sometimes. So it's one of the most famous examples of that was Jack Nicklaus. Jack Nicklaus had a ceramic on ceramic hip and was at a golf tournament one day, and he bent over to put his ball on the tee, and his hip went, and he looked up and he said, "Did you guys hear that? That was my hip." The company that made his hip went nuts because this was out there, and they literally scoured the internet and started grabbing everything to try to remove the video from everywhere. But Squeaking and ceramic. The problem is this. The hips are very, very, very finicky about positioning. So it seems like it would be really simple to just, replace the ball, replace the socket. But it's a three-dimensional, there's the variation in how it can go is so large. And ceramic on ceramic hips are very, very, very finicky about being positioned just exactly right. Now, it doesn't have to be positioned 100% exactly right to work like it's supposed to and not dislocate. You have a range that you can put it in, and that varies around from person to person depending on, how tight your hip is, and there's a lot of different variables that go into this when we're doing that hip replacement, but there's a range where you can do a hip replacement and expect a great outcome. That range for ceramic on ceramic is really, really, really small. And if you're outside of that range at all, then you can get these impinging or squeaking noises that'll happen, when people bend over. Now, that's not a all the time or super, super common thing, but it's kind of humorous to me. I mean, every time we go to a conference or something, some guy's got a video, some guy's sitting there doing this, and his hips just going, so. The bottom line is that you would use ceramic on ceramic generally if you were very young and particularly if you were female.
Okay, I want to know, as you get older, which is best, the implant or the injection, or does it have?
Well, I think that depends in all honesty. I think you'll get different answers to that question depending on which doctor you talk to in all honesty. I will tell you my opinion. And my opinion is this. Knee replacement's a very good surgery. Hip replacement's a very good surgery. Shoulder replacement's a really good surgery. I mean, it's a good surgery. But they're big surgeries. And if you can avoid it, it would be my preference that you not have it. I mean, in all honesty. Now, it's assuming that we can treat you effectively, conservatively. If I can treat you effectively with intermittent injections, intermittent anti-inflammatory medications or Tylenol, or something like that, and you can do what you need to do, and you're not restricted, then there's no reason for you to have surgery. So we don't treat your x-ray. You shouldn't have your x-ray treated. You treat you individually. And again, the answer for you is not going to be the same as the answer for him or the answer for him or the answer for her. It really needs to be individualized to what you're doing. And I keep going back to it because I have several patients who are that way, but if you have terrible lung disease, I'm going to do everything I can to keep you out of the operating room. If you're young and healthy and you want to be doing stuff and you're limited in what you can do and the injections make it feel a little bit better but you still can't get up and go do what you need to do, I'm going to tell you that you should probably have the joint replacement done. So I mean the bottom line is this is a quality, it's not an emergency ever. Arthritis is not an emergency. I know it feels like it sometimes because it hurts so bad, but it is not an emergency. It will not kill you. It's a quality of life issue. And so if you are stuck in your house and you can't go do it, you can't go walk around Walmart and go shopping for groceries without your knee killing you, and we're giving you injections and that's not working, then you need to get a knee replacement.
So age doesn't matter?
Not officially, but I mean the bottom line is this. The older you get, you're probably not in as good a you're theoretically not, the higher your risk from a surgical standpoint. When I was in residency, we put a knee replacement in a lady that was 101 years old. Now, that is not normal. I will say that up front. That is not a common thing that we do. This lady was in fantastic shape. She was very mentally with it. She knew what was going on, and she looked at us and she said this, "Listen, I'm not stupid. I'm 101 years old, but I am not going." She said, "I am not going to live whatever I got left stuck in my house, not able to do anything, and that's where I am right now, and I can't do it because my knee hurts. I know good and well I could die having this surgery done, but I would rather that happen than be stuck in my house for the rest of my life." The decision on knee replacement is yours. It really should. It really is. Your doctor's job is to, give you options, to instruct you on what they believe the best thing is to do, to guide you, through this process, and to help try to protect you. There are situations like that where this lady says, "I know what's going on." And again, she's totally mentally with it. She's not demented in any manner, doesn't have Alzheimer's or anything funny like that. And she says, "I know I could die having this surgery, but I'm stuck in my house, and I've lived for 101 years, and I've done a lot of stuff, and I'm not going to be stuck here the rest of my life." I mean, she did fantastic.
I wanted you to touch on the Tylenol arthritis medication at some point. If you'll just share what
Okay.
at some point.
Oh, yeah.
What criteria would you use in making the decision of whether to see an orthopedist or a rheumatologist? Now, I have both types.
Generally speaking, and rheumatoid. Generally speaking, an orthopedist is going to treat single joints. I mean, maybe bilateral knees or both knees or something like that. But if your complaint is my shoulders hurt and my elbows hurt and my knees hurt and my hips hurt and my ankles hurt, I can't help you very much with that. I mean, in all seriousness, I don't mean that to sound ugly, but I mean, I'm an orthopedic surgeon. And I don't want that to sound wrong either, because I mean, we just went through this, and where I told you my goal is to keep you out of the operating room if we can. But really, I'm a fixer. I mean, that's why I went into what I'm doing, because I want to fix the problem. If it's everything hurts, I can't fix that. I mean, there are medications that you can take from a rheumatoid standpoint, but those need to be guided by a rheumatologist, not by me. So if it's my knees hurt, I'm the person for you. If it's everything hurts, probably a rheumatologist. Tracy had asked, we talked about it a little bit earlier, Tylenol arthritis is a little bit of a pet peeve of mine. Tylenol is a very good medication. I use it regularly. It's in a lot of different things that we use. It really drives me crazy that they're allowed to market that drug as an arthritis medication. It is no different than Tylenol, except it stays in your system longer. So it is extended release Tylenol. It is not. I don't know how that makes it an arthritis medication, and it bothers me a little bit that they're allowed to market that like it's specifically something different that treats arthritis. So, Tylenol arthritis is just plain Tylenol. It is an extended release form, which for some people is better. You don't have to take it as frequently. So, by no means do I mean this to say I don't think you should take the medication. Understand that it is not specifically treating arthritis. It's just treating pain. Some of those may help. Now, here's the deal on those. And that gets into a lot of different types of medications, too. So there's various different over-the-counter creams or rubs, as well as things like glucosamine and chondroitin and joint juice and things like that. These are not drugs, okay? According to the federal government's Food and Drug Administration, those things are not considered medications or drugs. They are considered dietary supplements. Now, what that means is this. They can claim that it will fly UFOs to Mars, and that it doesn't have to be true. Okay? So they can pretty well put what they want on their bottle. Now, most of those people are smart enough to not put some outrageously crazy claim on the bottle, but it is not evaluated by our Food and Drug Administration. We can get into a big discussion about government oversight into a lot of some of these things, but the bottom line is that the general job of our Food and Drug Administration is to try to keep dangerous drugs off the market and out of you guys' kitchens and mouths, and they do a pretty good job. They're very aggressive. They don't regulate those medications at all. So our research into things like glucosamine and chondroitin says that they may be helpful, but we're really not sure. They're at least probably not harmful to you. So to anything except your pocketbook. So if you can afford to take things like joint juice or things like that, and you feel like they help you, then by all means take them.
What about being gay?
Yeah, those are different. So these are Bengay and things like that, Icy Hot, BioFreeze. These are pretty decent things. They're not dietary supplements, and basically the way they work is similar to the way a TENS unit works, which is they're a nuisance to your skin. And so it causes your nerve receptors to reset and not feel it. So it kind of increases what it takes for your nerves to feel pain, if that makes sense. They're pretty good. So BioFreeze in particular is one that I really like a lot. I feel like it works pretty good. We use that, and the therapists use that a lot. But again, and they even have like pepper creams and various different things like that. But all this kind of work the same way, which is you put it on your skin and it starts irritating the nerves, and it's like somebody coming up to you and just doing this. And then it's like, are they ever going to quit? Okay, I'm just gonna reset so that I don't feel that anymore. That's what your nerves say. So now you've jacked up the level that it takes for them to feel the pain, right? So now that works for other things other than just that too. So they were pretty good.
How long do knee replacements normally last?
Good question. Our standard answer is 10 to 15 years. 10 to 15 years for a joint replacement, but either knee or hip. And that is related again to the weight, to the plastic and how long the plastic wears out. This is something that is constantly being researched, and there's a ton of money that gets put into this every year to try to find plastic that works better. The plastic that we're using now, particularly for your hips, we believe is going to last substantially longer than what we've used in the past, but the bottom line is it hadn't been in people long enough to really see those results. In the lab, it shows very, very little wear. You are not a lab, and people are different, and so we say generally 10 to 15 years. The bottom line is the younger you are, probably the less time it's going to last when you get it done. So if you put a joint replacement in a 20-year-old, they don't last that long. You put a joint replacement in an 80-year-old, it's probably the rest of their life.
I have a sister that's had both knees replaced, and she's having an extreme pain now. And she went back to the surgeon, but he told her it was tissue built up,
Right. Yeah,
Tissues was a problem.
How far out is she from her surgery?
Oh, she's at least 10 years.
Yeah.
I think.
I would be worried that that's getting towards the life expectancy on her knees. There's various different things that can cause you to have pain after a knee replacement. Wear, malposition of the components. I mean, again, there's this window for what does good. It's not just, it's not super, super simple to do these. Everything is aligned. We have very good instrumentation now to help us do these things. It's way better than it used to be, and we can reliably put in knees, in a good range. But every now and then, people are just a little bit different. So, malalignment of the components or the kneecap component can sometimes cause pain. Infection is a disaster in a total joint. It is, and that's why. I mean, if every time we did a total joint everything went great, then I'd just say whenever you got arthritis, let's just replace your knee. But an infection is a disaster in a total joint. I mean, if you get an infected knee, that is a big, big, big problem. It is not simple to fix, and even if you do get rid of the infection, you end up with a knee that doesn't work anywhere near as good as it should, or as good as it would have if that had not happened. So there's that you have to be put to sleep. It is a stress on your heart and lungs. It is effort after surgery. I can do a perfect job on a knee replacement, and if you don't move it afterwards because it hurts, then you have a terrible outcome. All the stuff goes into it, and that's why I say I always prefer to try to treat you without surgery if I can. I mean, the bottom line is a lot of this progresses where we end up needing to do that, but if we can treat you effectively with injections and things like that, then I would way rather do that than put you in the operating room and end up and putting you through the risks associated with that. There are risks associated with everything, but the risks of me giving you an injection are way, way, way less than the risks of me doing a knee replacement on you. So knee replacement, hip replacement. The other one that we'll touch on just really briefly, shoulder replacement. But shoulder arthritis tends to be tolerated a little bit better than hip and knee arthritis for the only reason being that you don't walk on your hands. And so, you don't put as much pressure through your shoulder as you do on your hip and knees. The issue with shoulders is rotator cuff. So your hip joint's a really good joint. Ball in a socket, it's oriented like this. You pretty well have to break something or have a car wreck or something for your ball to come out of the socket. Your shoulder's a ball on a wall. It is pretty well stabilized by the tissues that surround your shoulder, and in particular, ball and socket of your shoulder, your rotator cuff comes over the top like this. It helps keep your shoulder from being able to come up like this, unless it's torn, and then your shoulder can ride up. So the problem is, once again, rotator cuff disease, like arthritis, is a wear and tear disease over time. So you got a 70-something-year-old that has shoulder arthritis, and a lot of times they have a rotator cuff tear associated with that as well, and that becomes a very difficult problem. Shoulder arthritis, similar to hip arthritis, replace the ball, replace the socket. If you have a rotator cuff tear, though, what they figured out is this. If you replace the ball and you replace the socket and there's no rotator cuff to hold it in place, the shoulder dislocates. So there's a solution to that. Replace the socket with a ball, replace the ball with a socket, and then this can't go up because the ball holds it in place. That's called a reverse shoulder replacement. It's a very specialized surgery. We don't do shoulder replacements here, either normal or reverse. But if you have really bad arthritis in your shoulder, we generally will treat that with injections, and then if not, then we can send you off to get a shoulder replacement done.
Are there any blood tests that can be done to identify the enzymes in your system which may cause the inflammation that comes with these problems?
No, not that I know of. I mean, I don't know of anything that we can do for that. The bottom line is that anything you see anytime you see a doctor hand you a sheet of paper and it ends with ITIS, That's inflammation and irritation. That's what the itis stands for. Arthritis, bursitis, tendonitis. Inflammation, irritation of whatever was ahead of that. So inflammation, irritation of the bursa, inflammation, irritation of the tendon. So, I don't know of any blood test that we have that will, determine that. If you have this stuff, you're going to have inflammation and irritation. And again, the anti-inflammatories or the steroids are good problems for that. But the problem you'll find is this. The steroids generally work really, really good, either by mouth or by injection. And a lot of times you'll see people that have, like you were asking, multi-joints, rheumatoid or something like that. You put those people on steroids and they feel great while they're taking them. As soon as you take them off, then a lot of times it just comes back.
If the osteoarthritis in the knee is the wearing away of the cartilage, how does the chicken shot improve that?
Well, good. I have no idea. I mean, we don't know. So the theory is that the medication, again, is hyaluronic acid, which is a normal component of your fluid, and they think that it just somehow modulates that fluid. And we always tell people it's kind of like changing your motor oil and changing to a thicker motor oil, and it just lubricates better. How that relieves pain, and we don't know. No, absolutely not. And I'm glad you said that, because regardless of what you read, you can't regrow that cartilage. I mean, we can take cartilage cells out of your body and put them in culture and grow cartilage and put it back in for small defects in your knee, but not on a global scale. So regardless of what the medication claims or the commercial claims or whatever else, right now I will tell you, you cannot regrow cartilage. So if you see that, that's just a lie. Right. It's just not true. And we are not regrowing cartilage. And that's why I made the comment earlier. We're treating your symptoms. The cartilage is gone. And that, again, gets into the common misconception that arthritis is something that's in there that's not supposed to be. So people are like, just get rid of it. Well, it's something that's already gone. That's why we can't, that's why it's so hard to treat.
I suppose my case is kind of, I don't know if you're going to use your knowledge, I don't even know. I have you told me something about my sciatic, or something about my spine, or it's not my hip, but
right.
It feels like my hip.
Right.
And it pops and goes on, and it gets sore. And right now I'm doing physical therapy. But what do you usually do, with that kind of
Well, that may just be arthritis in your back. So you can absolutely get referred pain from your back to your hip. You can get referred pain from your hip to your knee. So in other words, people that have a hip problem can complain of knee problems, can complain of their knee hurting even though their hip hurts. Interestingly, kids in particular will come in with this one thing where they'll come in saying they got hit in their knee, and we'll see them where they've been treated for long periods of time generally, and somebody looking at their knee, and you check their hip, and they've got what's called a slipped capital femoral epiphysis. And that's really fun to try to convince a mom that you're fixing to operate on their kid's hip when they've been complaining of their knee hurting for a year and a half, right? Yeah, and then that takes a lot of talking. Anyway, so that's called referred pain. It's related to the fact that the nerve that innervates your hip continues down and innervates your knee as well, and so your body can kind of get confused sometimes between those two. But in relation to sciatic, arthritis in your spine, similar to arthritis in your knee or your hip, one of the things that happens over time as that cartilage wears out, your body sees that as an increased stress to whatever joint that is. And so one of the responses to that is to lay down extra bone to try to relieve that stress. And so around the knee, we'll see what's called osteophytes that'll form. This is these little branches of bone that'll form around the knee on both sides. That can happen in your spine as well. So where your joints come together for the vertebrae in your spine, that's called your facet joints. And you can get arthritis there, and that arthritis can push toward or impinge or press on a nerve root. And that'll give you pain that radiates anywhere that nerve root is going. So think you got a water hose that's turned on at the faucet, and you go grab halfway down the hose, and you step on it, you get no water from wherever your foot is out. So anywhere from where the injury is down is where you get the symptoms. So it's the same thing with a nerve in your spine. Where it gets pressed down is where you're going to get your symptoms. And typically those nerves go from your back, and for most things, L5 or sciatic, down the back of the leg, outer part of the lower leg, into the top of the foot. So people will complain typically of pain that radiates into their hip or into their buttock and down the back of their leg and even into their foot.
Enjoyed it, and I'll be talking to you.
So what you have is probably arthritic related to that. So treatment-wise for that is very similar to what we've talked about. Your options really are range of motion exercises, therapy, medications, injections, or surgery. And so your next step if therapy doesn't work is likely epidural steroid injections. So they do the injections, they just do them in your back. The problem is.
Question, sir. Do you ever use cadaver joints? Cadaver joints?
I'm going to tell you yes, but not for a typical primary joint replacement. So, in other words, if you just came in and had, arthritis of your knee, we would replace metal and that kind of stuff, or arthritis of your hip. For people that have to have joint replacements when they're young, or that have tumors or things like that, where you have to remove extra bone, you can do all types of different stuff with cadavers. So you can do an entire femur replacement, a hip replacement, entire metal rod into a knee replacement. That's called a total femur. I've done a couple of those in training. When I was in training, I don't do them anymore. But you can do all kind of stuff. We can take from here up on a cadaver and attach that, like if you had a tumor or something like that, that caused you to lose part of your bone in your hip. We can take the top third of a femur with the ball and socket, with the ball, hook it into yours and put a rod or a plate on it and hold it all together. For shoulders, you can do, there's various different things that you can do for those as well. So for standard primary joint replacements, we're not doing any of that stuff. For revisions, you can get into some crazy stuff.
Well, I have cadaver socket and steel ball in one shoulder, man-made socket and steel ball in the other shoulder.
Yeah.
And I think the cadaver side works better.
Yeah. You start getting into crazy revision stuff, you got to go talk to that man. This is my partner, Dr. Gay. He actually is a joint replacement specialist. He's specialty trained in joint replacement. So, I do some generalized knee replacements. Most of the hips, well, all the hips, we let Dr. Gay do now, and anything, like joints that have worn out and have to be redone, like a 15-year-old joint that has to be redone. He does those. So we do most of that stuff here in Dublin now. Yes, ma'am.
Are you familiar with the medication Vimovo?
Yes, ma'am. Yeah, it's an anti-inflammatory with remember the first thing I told you about the anti-inflammatory is a stomach problem. So there's a lot of different medications that have come out to try to address the stomach issues. Celebrex, was designed specifically to try to avoid the stomach issues. Mobic as well. And then Vimovo is very similar. They've added stuff into it to try to prevent stomach issues. And there's a medication on the market now called Discussess, which is 800 milligrams of ibuprofen and Pepcid in the same pill. I personally really, really like that medication. I use it. I have some issues with my back, and I use that a lot. But a lot of these medications have come up with some way to try to avoid the stomach issues. The bottom line is this: if you really have bad stomach problems, you just shouldn't be taking those pills. And if you have bad stomach problems or bad heart problems, you shouldn't take them. And that's what we see a lot of times is that, again, this would be fantastic if you guys were all 20 years old and you didn't have any medical problems, but that's not the way it works. Most of you guys have high blood pressure, hypercholesterolemia or high cholesterol, plus minus some kidney issues. And if you have kidney issues and high blood pressure and hypercholesterolemia, you can't take anti-inflammatory medications. And that's where your Tylenol arthritis comes in, even though it's not arthritis.
Okay, but with me, I can't take the Tylenol because of the liver.
Mm-hmm.
I used to have a liver problem. I don't have no more, but anyway. And I had ulcers when I was real young. So it's not really nothing we really take. No,
and again, this is where, for an instance like that, then most of the time what I'll do is just, I will send you to see a pain management doctor. There are times where you see people that have arthritis and you say, look, the ideal solution for this is probably that you need a knee replacement done, but you can't have it done based on your medical problems or the risk or whatever the problem may be. And for those folks, we tend to refer them to pain management. The bottom line is if you're going to require long-term narcotic medications to control your symptoms, then that's not what we do.
That's after injections.
Right. Yeah. Yes, ma'am.
Aspirin works better for me than anything. Oh, my arthritis, it helps my pain better. So you see anything wrong with that?
No. And a lot of you guys, and that's another issue actually, is that aspirin, an aspirin a day is what a lot of folks are doing now for just generalized,
Maybe aspirin at night.
right, cardiac protectant and that kind of stuff. So if you're taking aspirin already, that's a type of NSAID, and so you take aspirin and add another anti-inflammatory on top of it, that's not good either. So, again, a lot of these things are reasons why anti-inflammatory drugs, which again are the mainstay treatment for this, are just not good options for a 60, 70, 80-year-old. Aspirin's okay. That's fine. It's a type of anti-inflammatory.
Don't mix it with another.
Yeah, we don't want you taking a bunch of ibuprofen on top of that or Advil on top of that, but yeah.
Well, it works better for me than ibuprofen on my pain.
And what you'll find, and that's, again, it goes to what I said earlier, which is we treat individual patients, not just arthritis. And so, I'll always remember when I was in medical school, I had a couple when I was doing a rotation when I was in medical school. And I was doing at the time a study on these medications that prevent reflux. And there's Prilosec and there's Prevacid. Now, for all intents and purposes, they're the same medication for what we know. Somebody took a hydroxyl group took a chemical group on the non-active part and changed it and made it a new medication so that they could make money off of it. But for the active part of the medication is the exact same. So as far as we're concerned, Prilosec and Prevacid are the same medication. These people were hilarious. He took Prilosec, and he said if he took Prevacid, it didn't do a daggum thing for him, and she was the exact opposite. Now, that doesn't make any medical sense necessarily, but that's the way it is. That's just their individual patients. I know for me, I take Advil, or ibuprofen. Ibuprofen works fantastic for me. Naproxen, I tell my patients a lot to take Aleve because it's twice a day instead of 4 times a day. It should work. It should be the same. It should work just as well. You should just not have to take it as frequently. When I take Naproxen or Aleve, it doesn't seem to work anywhere near as well for me as when I take ibuprofen. You may be the exact opposite. You may take Aleve and it works fantastic, and ibuprofen doesn't do anything for you. Some of this is trial and error. You have to just say, try these different things and see what they do. Every person is individual.